Hello, Ewa.
Hello, John.
How you doing?
Do I have busy with many webinars?
Oh yeah, you've been doing a lot, right?
No, you.
Oh yeah. It's great. It's great. Well, you know, this is the new television, Yuha.
Mm-hmm.
The television will be obsolete. It'll be all internet, and we're getting better with production. With Warlick. Warlick is really making some good little videos, like for announcing, etc. I'll send you one. Oh, I'll show it to you. I'll show it to you. Warlick is coming up. Warlick, you there?
She's there.
Let me see if I can screen share it here. Hold on. Okay. Now I get a chance to screen share. Okay. Do you see this, Yuha? Do you see it?
Yeah. And this was in Facebook.
Yeah. Warlick just did this video.
Yeah.
She's making it very dynamic, the announcements. See? Oh, can you probably can't hear that. Let me play it again. I'm sorry. I didn't put the sound on.
Hi, welcome to
Hi, this is Dr. John Bennett of Neurosurgical TV. I'd like to make an announcement. This Thursday at 4 o'clock, we're interviewing the head of this excellent neurosurgery group, Neurosurgery Cocktail. Everyone knows what it is. So we're going to have the originator, Bipin Chaurasia, neurosurgeon from Bangladesh. We're going to be talking to him about how we started this platform, and see you how we're going Hollywood.
Yeah, it seems to be so. Yeah.
You know, I just think we can make the website more dynamic, and not just announcements, you know, like getting to know the people behind the project and the website, so they can hopefully learn their personality and become attached to them. Hey, Marco.
Hello, John. How are you?
Marco, have you met Yuha yet before?
No, never. It's my first time.
Oh, nice to meet you.
Nice to meet you too, Professor Neshemi. Pleased to meet you.
Yeah, Marco is doing a webinar on peripheral nerve injuries.
Mm-hmm.
So he's had one. He's going to have another. The next one you want to change, Marco, right, to the 19th?
Yeah, it could be a good time for me.
Okay, yeah. Well, just after, you know, I got to make sure I'll check the schedule after. Okay.
Of course, take your time.
Okay, his AJ is coming. Hello,
hey,
AJ.
Hello, good morning. How are you doing?
Good morning. I'm John Bennett, the host, and you know Yuha, right?
Yes, I know him. Of course, who doesn't know him? Hello, good morning, or good afternoon, or good evening.
Good evening from here. Warlick is now here also.
There's Warlick. How you doing, Warlick?
Okay.
Hello, good morning or good evening. How are you doing?
Well, let me get, I'm on hogging the spotlight there. Hey, Warlocks, that was a great commercial. That was really good.
Yeah, I did it before. I attended a case, not good one, but
That
yeah.
was fast. That was fast. Well, we'll get better at it. We need to edit it a little bit. But it's another dimension to the media. I mean, we're making the 2-dimension into 3-dimension video.
Your like advertising and your like promotions and how did you encourage me? So it's make the neurosurgical Congress of Thailand want to change the how to promote their brochure for their annual meetings too by using my art too. So like a lot of work.
Yeah, well, yeah, why not? It's great. Okay, we start in 4 minutes, sir. Yeah, we're waiting for Ben, right?
Ben is late. He asked if he could be the last presentation.
Oh, okay.
So after me would be the Professor Vaklu, and then Luis, and then Subin. He has an operation, so he sent a message.
Okay, you got that, Warlocks? Did you hear that? Okay, okay. Because you're kind of organizing it, Warlocks, like who's next and the questions, okay? That's a nice shirt.
Yeah, it's make other people like easily recognize me as neurosurgeon more.
Oh, okay. Three minutes, Warlocks.
John, which time zone are you in? Right
I'm in
now?
Miami. I'm in Eastern
You are
Standard
in,
Time.
you are
How
in
about you? How about you, AJ? Where are you at?
Boston. I'm here in Boston.
Oh, okay. So you got up early too.
Yes, that's why I need my coffee here.
Yeah. I gotta have that coffee. I went across the street to get it. But yeah, you gotta when you do what I do, you gotta get used to all time zones.
Yes, I can imagine.
It gets confusing, very confusing, because time zones change.
Yeah.
Occasionally, and you got to really keep up on it.
Yeah.
Where in Boston are you, AJ?
I'm at Tufts at the university, and I practice at Beth Israel Lahey Health here.
Oh, okay, very good. Yeah, I went to Brown University.
Oh,
I
yeah.
think they had some kind of affiliation with Tufts, right?
Yes, but they have their own excellent medical school. It's really a primary school. It's great.
You remember Pierre Galletti? Ever heard of him?
Yeah.
He was a big transplant guy, right? Or
Yeah.
is he doing okay? I haven't seen him in a long time.
I don't think that he practices. Does he still practice?
I don't even know. I haven't heard about him for years. I haven't really looked at it. But he was big at Brown, a couple of years ago. Oh, so no China televising, right, Yuha?
Yeah, but I don't know who is translating now when Subin is late. Is Dr. Liao?
Okay, I don't know. Dr. Liao, are you here? I guess not.
Okay, then we are lacking translation in Chinese until Subin is coming.
Okay, we'll just start. And you want to start, or you want to wait?
Yeah, we will start.
Okay. 1 minute. 1 minute, Warlocks. And he'll just join in. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for the NeuroIMC. This is number 5 in the group, and I'm going to turn it over immediately to the multi-talented Warlocks, the neurosurgeon from Thailand. Welcome, Warlocks.
Hi, Johns. Hi, everybody. So today, welcome to everybody's again. So today we have 4 speakers. 2 of them are neurosurgeons who have a lot of experiences, and the rest is the neurointerventions, in which today we have really interesting topics about vertebral basilar complex aneurysms, microsurgery versus endovasculars. So I would like to introduce our first speakers. That will be the microsurgical side first. Professor Juha Haneshimi, he is the Finnish neurosurgeon and Professor Emeritus of Neurosurgeries in Finland. He specialized in microsurgeries in aneurysm and AVM. Currently, he works at the Henan Provincial People Hospital, Changshu in China. So today, Professor Juha will give a talk about his experience in microsurgeries in vertebral basilar complex aneurysm part 1. Please, Professor Juha.
Hello, everybody. So I will speak on, Speak on complex aneurysms of basilar trunk. I wanted to ask Luis which aneurysm should be included. So I have 5 videos. I can skip 2 of the videos because they are on the vertebral aneurysm. So maybe we take that later. So I speak about aneurysms of basilar trunk and vertebral basilar junction. I'm working now 3rd year in Zhengzhou, China. And this is the background with aneurysms. I made my lifetime work in Finland, 17 years in Eastern Finland, Kuopio, and then 18 years as a chairman in Helsinki. So we have good databases on these both centers, more than 18,000 patients with more than 22,000 aneurysms, and out of them, 2,000 are posterior circulation aneurysms. I have a personal experience of more than 600 vertebral basilar aneurysms operated on by microsurgical means. So in the Finnish databases, this is the site of the aneurysms, and you will see that there's a higher number, 16%, than in earlier publications in our material, because we did CT angio last 15 years as the diagnostic tool. So all the vessels, all the arteries were always seen. And these are the site of posterior circulation vertebral basilar artery aneurysms. So at the basilar tip, at basilar bifurcation, basilar superior cerebral artery, and P1 around 45%. Then around the same number at vertebral or pica, and then at the basilar trunk, vertebral basilar junction, around 10%. So this is the distribution in our series. And speaking about basilar trunk, vertebral basilar junction, so to operate on them, you have to have certainly a proximal control, otherwise you cannot clip them. So you have to put 2 or 3 temporary clips on vertebral basilar arteries. You have to take utmost care of the perforators, because lesioning even one perforator, the patient might be invalidized and never recover independent state. And one of the important simple things is that the clip length must be 1.5 times the base of the aneurysm measured in the imaging. Surgical strategy, there are different aneurysms. You have unruptured aneurysms, you have acute ruptured aneurysms, and then you have emergency aneurysms. What are they in posterior circulation aneurysms? In my experience, if you had in one day many repeated bleedings, so we operated on also in the evening or even in the night. And then you have very difficult aneurysms. Advanced approaches are needed in large, giant or fusiform aneurysms. Surgical strategy, pre-sigmoid approach has proved to be very good for basilar trunk, for vertebral basilar junction aneurysms. You are doing Parkman's position, making partial petrosectomy and going in front of the sigmoid sinus to the skull base. you have to have spinal train, have slack brain and enough space. And if the aneurysm is very low, then you can eventually use retrosigmoid approach, but usually not in basilar trunk or vertebrobasilar junction. So this is the first video. This is, I think this is a vertebral aneurysm. Unruptured left vertebral artery aneurysm. It was clipped, but it proved in the control angios that the aneurysm is still filling, so the clip to close the vertebral artery below the aneurysm is not long enough. It is not occluding the whole vertebral artery, so we made a reoperation, and the complexity of this operation is shown that you are doing a reoperation, so you have a lot of scarring, and you have to very carefully dissect there. I use the dissection under microscope because there are scarring and adhesions, and you see it is not so easy to go lateral to the cerebellum, but then a lot of scarring, and we go down, and then we come to the clip that is not occluding totally the vertebral artery. So again, scar. The difficulty in the vertebral aneurysms is that they are close to 9 and 10 cranial nerves, and the patient might have swallowing difficulties. You have to check extremely carefully after operation if the patient can swallow or not, because if there is difficulty in swallowing, the patient is in big danger to aspirate, and this is life dangerous. So I always say that the 9 and 10 are the most important cranial nerves. And here you see the clip. And you see the fusiform aneurysm, thick wall. Why are we operating on these aneurysms? Because we don't know exactly how the wall is in the angios. Here I check the situation. One of the difficulties here is, of course, to have the clip inside the applicator, not to disturb the cranial nerves, checking carefully here. And I push my dissector there to see all the surrounding there. Again, scarring arachnoid, sharp dissection. And now I try to open the clip. I don't remember how long time after the operation this reoperation was done after the first operation, but you see a lot of scarring and the difficulty to have the clip in a applier. Should be also careful when opening the clip because there might be scar around the clip, so you might have difficulties. I try to open the clip and then advance it deeper to have total proximal occlusion. You may say we should not occlude the arteries. We have made a long-term follow-up study of carotid occlusions in giant aneurysms done in the 70s and before the microsurgical era in 60s and 70s, and with the extremely long-term follow-up, there were no big difficulties in these patients who survived the operation of carotid occlusion. So now I put another clip above the first one, old one, and then this is long enough, and you see there is some manipulation of the cranial nerves. So you have, but this patient didn't have any difficulties. So could swallow after operation, but you have to check extremely carefully the swallowing. And then checking with Doppler. And this is the post-operative picture. You see that the aneurysm carrying vertebral artery has been occluded, but there is good collateral flow from the other side, and so the patient has no difficulties. So you can assess that before operation, of course. Then there is also vertebral aneurysm, complicated aneurysm, because it is a dissecting aneurysm, right ruptured vertebral artery aneurysm, very severe subarachnoid hemorrhage. And you see that there is a dissecting aneurysm and big narrowing in the vertebral artery after the aneurysm. So, because the other side is extremely strong, we felt that we can do trapping or proximal occlusion of the aneurysm. You see there is a very severe subarachnoid hemorrhage. This is right side. Patient is in Parkman's position, very bloody subarachnoid bloody CSF, and then dissecting downwards between the cranial nerves, sucking the blood here and cleaning the field with irrigation. And soon we should see the dissecting aneurysm. So I put the temporary clip proximally on the vertebral artery, and then I want to clip the aneurysm or also the vertebral artery. I select clip here. This is not proper clip, so the aneurysm begins to bleed. I have to change this. Now I took the temporary clip out, but when dissecting here, the aneurysm begins to bleed, and I have to repeat the temporary clipping. Try to, not yet, but I try to clip the aneurysm and the vertebral artery with this clip. It is bleeding now from the aneurysm, so I have to put temporary clip back. Again, the vertebral artery. Take the clip out here. This very narrow gap, narrow space. So now I take a more curved clip, and this will take the aneurysm and the vertebral artery and stops the bleeding. And still checking the situation. The golden color clip is the temporary clip, and now the more curved clip is going there and taking the whole aneurysm and temporary clip removed. Doppler, probe, this IC angiography. Actually showing a good flow in the vertebral arteries, only the dissecting aneurysm was taken. And this is the situation after operation. We see several clips. Okay, then we go to vertebro-basilar junction at several basilar trunk aneurysm, but I think these vertebro-basilar junction aneurysms are more representative. Here is a ruptured vertebro-basilar junction aneurysm. You see a large, close to giant aneurysm at the vertebro-basilar junction and also a small pica aneurysm. This is a presigmoid approach. the anatomy is here difficult, but what I'm doing now, I'm putting temporary clips on both vertebrae. Arteries below the aneurysm. And then I have to have a temporary clip also above the aneurysm. Otherwise, the aneurysm remains tense. So here, now I have on both sides, I have the temporary clip, both sides of the aneurysm, and now we dissect the aneurysm base. These vertebrovascular junction aneurysms are always located at the fenestration at the vertebrovascular junction. So the first clip is going here. Fenestrated clip taking the strong base of the aneurysm. And now taking temporary clips out. This should not be long time because you are closing all the basilar trunk. So, but now we can see that the clip is not proper. It is crushing the basilar artery, and you see that inside the clip there is a small important perforator. What to do now? You should not take the first clip out, but use it because you have made your best to have the clip in the place. So you take another clip and put it distal to the first one. Long clip. You have to have long clips. You have to measure the base of the aneurysm before you operate on. The clips must be 1.5 times the base of the aneurysm, and here base is big. So now this long clip is closing distal to the first one, and I still put the one more long clip before removing the first one, which is occluding the perforator and one part of the basilar trunk. It is too tight. This first clip is too tight. So one more clip is added here. Long, strong clip to take all the base of the aneurysm and to help the other clip. And then the first clip, primary clip, is removed. And now you see the perforator is free after removing the primary clip, and these are the control angios. And then the next case was done in Padua. This is 2001. We were asked by Professor Scienza, Professor Giancarlo Perra, to operate on a Croatian student. I went with my fellow Keisuke Ishii. This is a local neurosurgeon, Giacomo Pavesi, and our scrap nurse, Kaisa Kuhmula, and Giancarlo Perra. So this was a good team. So we went there to operate on in Padua. We made two.
Excuse me, Giancarlo's here.
Yeah, good, good, good. I put the music away. Okay, this is the vertebrovascular junction aneurysm. So this is a difficult, giant aneurysm. It was in a young student, and so we made two unruptured aneurysms before that same day, in the morning and midday, and then around 2 or 3 o'clock in the afternoon we began to do that. And after these two, what we call warm-up operations, we were ready to do this extremely difficult case. So this is patient in Parkman's position, pre-sigmoid approach. I had some difficulties in doing the pre-sigmoid approach. Even the patient was very young, so I had a lesion in the sinus. I had to ligate it, and I was very worried about that. And she didn't have any difficulties here. So this is the 7-8 complex, facial, statoacousticus nerve, and then we go down. What are we dissecting? We want to see both the vertebral arteries here to put the temporary clip on them. In this case, they were extremely close to each other, like you see here. So I could put long temporary clip on taking the both vertebral arteries. And going more down, you will see that there is manipulation of the 9 and 10. Here is 9 and 10. So I was extremely worried that the patient has swallowing difficulties, and I was telling Giancarlo and Renato that they should keep the patient intubated and maybe make a tracheostomy. But the patient didn't have any swallowing difficulties. Even I'm manipulating the nerves here. Now we have the situation here. We should ready. So the temporary clip should go on, checking the flow here with Doppler, that time Doppler. And this is the very big aneurysm, giant aneurysm buried inside the brainstem. So now the long temporary clip is going around both vertebral arteries, and then we have to go above the aneurysm to put the temporary clip on the basilar trunk, going here. So now we have temporary clips on both sides of the butterfly aneurysm, which giant part is buried inside the brainstem. And here dissecting on the strong base of the aneurysm. And then taking the first clip. This is a fenestrated clip according to Drake principles. First clip should be fenestrated clip because it is not slipping away from the aneurysm because of the fenestration, advancing it deeper and deeper, and then slowly closing. And this is now successfully there. So we have to put a straight clip to close the fenestration, long clip to take all the base of the aneurysm, and then the aneurysm is done. There is an anterior part of the aneurysm. It is like the butterfly aneurysm. So against the clivus, there is another part coming from the fenestration, and this will be taken by clip. You see that the strong-based aneurysm is spitting the clip away. It's not accepting the clip, even there are temporary clips. But then pushing the curved clip more close to the basilar trunk, I could put it in place and then adding a second one. So using the double clipping technique where the first clip is pressing the second one down. So here, the second clip is going below the first clip, and this means that the first clip is pressing the second one down, and then the aneurysm is totally taken, and then now we have to take the temporary clips out, and it's not so easy. So this is the vertebra clip, and here above is the basilar clip. Temporary clip, this can be taken out, but then we have difficulties in taking the temporary clip from the vertebral arteries you will see. Also here you have to manage between the cranial nerves. I put a patty to protect my applicator from the, and now I can take the basilar artery clip away and then going down. And this clip is stubborn. This temporary clip is stubborn. It is hiding behind the other clips, and I try to dissect it in proper position, take it out. It is turned, so it is difficult to take out, and I was rather desperate there because the time is going. Now you see that I'm going with my left hand. My left hand is by far worse than my right hand, so but I had to take the temporary clip out with left hand. You see that my left hand is not so accurate, but I could manage, and of course very much relieved here. Opening the clip slowly and then taking out, and then the vertebral arteries are free, and the flow in the vertebral basilar is okay. And now this is the final situation. Strong clips on both sides of basilar artery, and then we puncture the aneurysm, the giant part of the aneurysm, and go inside the aneurysm with sharp bipolars. And then papaverine put in surgery cell, and this is the final situation of the operative area. And we made also later Padua control angio was done DSA, and it shows perfect clipping of the aneurysm. So I note that but this is the patient 3 years later, very happy, beautiful lady, doing well without any cranial nerve deficit. And she's now, I think she's a teacher and married. Giancarlo knows her fate better. Then there's one more video. I'm sorry I'm taking more time now, but I want to show this because this is something very special. There are these terrible aneurysms where the basilar dolichoectatic aneurysms, and usually you cannot do anything. Whatever you do, then you have difficult outcome, poor outcome. Dr. Drake had a girlfriend, and he operated on that kind of aneurysm, and the patient, his friend, died in this operation. So it shows how serious they are, and we know very well that they are very demanding. So here, what I'm doing here, this is Parkinson's position. I go to vertebral artery. This is C1. I'm drilling C1 and then identifying with Doppler. And this is how I'm making a clip that stays on the vertebral artery and wiggling vicryl around the clip so that when it will not close immediately totally. So this is how we did the first primitive clips. A lot of vicryl around the base of the clip so that the clip couldn't close immediately, but left the artery free. and more. So because you cannot close the dominant vertebral artery immediately, so it must close slowly to develop collateral circulation. This was the strategy in treating these aneurysms. I will come back to our later developments. This first series of 10 patients will be now published. The difficulty is that nowadays, when you have endovascular surgery, it is very difficult to get these papers published because they are totally different from the mainstream of the treatment of these aneurysms. But now it is the PhD study of a young doctor, Behnam Jahromi in Helsinki. He has big collection, 519 patients with these monstrous aneurysms, and now you see that the artificial clip is getting ready. And now we should have it around the vertebral artery. This is above C1. We have drilled part of the C1 away, and then we put the clip in place, and it is not so easy to have in place. In the beginning, we used straight clips, but they slipped. The time they slipped, so we developed this clip, and you see that it is not so easy to put it around the vertebral artery. So trying several times, not giving up. I have to turn the clip, I think. I have to turn the clip. This way it is not going well. Doppler checking. It will be not good like that. So take out, and turn the clip. Yeah, that way. Now it should be okay. It's turning, so must be totally around the vertebral artery, wiggling down, clip, and then letting it close, but it is not closing totally because the vicryl there, Doppler checking on both sides, and in the ICG you will see that the vertebral artery remains open, and then this is how we did. And of course you don't know exactly when the clip is closing because you don't know the resorption time of the vicryl exactly, but these were the primitive clips we were using in the first 10 cases. You see here the clip in place, and this is the CT angio after operation. So, as mentioned, Dr. Behnam Jahromi has huge collection of these aneurysms, mainly from Finland, but also international. He's doing his PhD, and it will be finished next year. 519 monstrous atherosclerotic vertebrovascular aneurysms. So, based on this initial experience with the primitive vicryl clips, we developed this clip with the team. So, this is a slow closing clip which you can manage. Just teleconnection. Remote control. With remote control, you put this clip is going around the proximal artery, and then you can open or close it with remote control. And this were the group developing the aneurysm. This is the young doctor Jahromi here. Where is my arrow? Yeah, this is Dr. Jahromi who is making his PhD on this huge material of vertebrovascular atherosclerotic monstrous aneurysms, 590 cases. My fellow, the Dr. Richard Asti now in New York, and then 2 watchmates, Sarpaneva and Hirvela. They developed this grip, and we hope we will get in use. So to speak about this difficult aneurysm, you have to ask, of course, can we do it again? Can we repeat it safely? And can someone learn it? So these are the questions. Nowadays, there's huge pressure from surroundings, media, colleagues, lawyers. So you need extremely supportive team, no angry eyes around you, no gossiping around you. Everybody in the operation room has to work for the most important person in the operation room, for the patient. So good teamwork is extremely important. This is Helsinki, extremely good sharpness, Hanna-Lena, and this is Zhengzhou, Henan Provincial People's Hospital, the same. Ping Chen, in instruments looking at the screen, and the instruments are coming. Good anesthesia, so good team means good operation. And this was Brain House Padua, Italy. So the young Croatian student was the first one, done 2001. After that, we went several times, even 2 times a year, to give a Brain House life course in Padua and some other northern Italian cities. So this was extremely good cooperation and always very supportive team. We did difficult aneurysms there. And this is Chicago 1988. I show always this picture because it shows the importance of learning anatomy even in the advanced age and after large experience. This is Professor Jasakil, 63 years old, and Professor Drake, 68 years old, looking at some subtemporal approach in a cadaver head. So who continues clipping? Only stupid people is saying, but it is also a question of money. Endoscopy means treatment is extremely expensive, so microsurgery in giant aneurysms, large aneurysms is by far cheaper. So finally, for all neurosurgeons to be highest level of neurosurgeon, good skills in surgery and English knowledge. Otherwise, you are only local hero and you learn from international connections a lot. And for China, don't save the beautiful Chinese hair, like here, female hair is torturing, this is Chinese practice. You should do minimal invasive shaving, here in the AVM girl. Make focused minimal invasive haircut. And all my videos are in the internet, free to get, and also Helsinki Microneurosurgery book in many languages. So thank you very much for your attention. I beg you pardon that I took too much time. Session, kiitos.
Thank you, Professor Juha, for really wonderful lectures and amazing skills. It's kind of like really difficult case, and for young neurosurgery, young like me to learn from you, that's really amazing. So next, I think we move to the endovascular sessions. So we will have Dr. AJ K. Wacklow, our guest for these sessions. He is the neurointerventionist in Burlington, Massachusetts. He's been practiced in and specialized in neuroendovascular treatment more than 20 years. So today he will talk about his experience in endovascular treatment in vertebrovascular aneurysms complex. So please, Dr. AJ.
Can you see my screen? Can you hear me clearly?
Yes, perfect.
Thank you. So first of all, thank you very much for the kind invitation to speak at this forum. I want to send good morning, good evening, and good afternoon to all the various continents. I will share with you the evolving endovascular field for basilar trunk and VB junction aneurysms. I have no disclosure statements for this procedure. I will share with you the early experience with stent-assisted coiling for VB junction and basilar aneurysms, then move to early experience with flow diverters. Then we present our largest series of flow diverters for basilar aneurysms. That has led also to a lot of teaching and proctoring in the United States and around the globe. And then share with you our recent changes in treatment of basilar aneurysm management with flow diverters. So there have been some adjustment that we have done over the past few years. When we started this journey using stents for intracranial aneurysms, we had early studies, research studies that showed that coil alone may not be sufficient for these aneurysms, and we may need to bridge the neck and the disease segment with a stent-like implant. And we did a lot of basic studies coming out of the lab showing that there was a reduction of flow impact within the aneurysm by using stent-like products. And we shared our experience then at that time, early experience that involved, of course, vertebral artery, VB junction, as well as basilar artery. The start was very simple. We treated some ruptured aneurysm, but this one, or unruptured aneurysm that had wide neck, to see the feasibility of stent. These were coronary stents. They were not engineered for the neurovascular arm. We used these stents in conjunction with the coils for this aneurysm. So here, placement of the coils and then bridging in what we call it in a semi-jailing or or dual catheter approach, where we reconstructed the vertebral artery to see also over long term whether we can have the patency of anterior spinal artery, as in this situation, and the larger branches over time. So the results, early results were very, very encouraging, and then we moved slowly to the basilar trunk. Here, a patient with mass effect on the mid-pontine area due to probably dissecting aneurysms. So we did the same technology. We placed coils and we bridged the whole thing with a stent, getting very satisfactory clinical as well as angiographic result. Now then we became more and more aggressive, and then this is a paper that came and compiled our study, and these were the patients in this series that had basilar trunk aneurysm. And you may say over time, these patients did fairly well using this technology. Some of the patients we have been observing now for over a decade. So that was very, very encouraging. And as we were moving the technology towards engineering of finer mesh products made of chromium cobalt and had the propensity to allow the tissue to grow over it, we thought that this would be the way to go. Here an example, another example of a probably dissecting aneurysm here, an entrance to the dissection and reconstruction with stents and coiling of the aneurysm. And this is a 108 months follow-up on the patient, showing you the perforators nicely open, and the patient did very well. Now, this is a more complex aneurysm that involved both ICAs, perforators, and the right vertebral artery. So we didn't know at that time, should we obliterate the right vertebral artery that could potentially lead to an endo leak. So we reconstructed this at that time with a wall stent, which was very heavy, which was very difficult to steer into the basilar vertebral system. But we managed to get it there. In some cases, we did even vertebral cut at C1, C2 to navigate those catheters up into the brain. Very challenging cases. And we ended up using over 100 coils. So these procedures were extremely expensive, as you can imagine, several $100,000 to reconstruct with stents these, and then placing several coils. This patient did very well. Over time, interestingly enough, the right vertebral artery obliterated on its own. and fed only the pica distribution. Very satisfactory results in these cases. Now then we, like I said, we started working on our flow diverters. The concept was carefully studied in extensive animal studies and engineered, finding the right sweet spot where we could preserve small perforators, and we are still working on those challenges, and yet keep the aneurysm from further growth. And these data were then later here published in AJNR in 2015, and I will go through the cases. As we got very encouraged from the early studies, we thought we could tackle these aneurysms. This dolichoectatic in a 60-year-old male, he was a physician. We placed the flow diverter here. We didn't close the right vertebral artery like I showed in the previous study. And you may nicely see here also the anterior spinal artery originating from the VB junction area. This was the longest flow diverter that we have generated here for this patient especially. It was an 8 centimeter to reconstruct the whole segment. As you see, we placed the flow diverter from the left vertebral artery and bridged the entire basilar trunk, coming from the terminus into the left vertebral artery where we thought the vessel was properly. The problem was we didn't close the right vertebral artery, and we had the patient only on dual antiplatelet without testing all the platelet functions. So initially, everything looked very well. The patient was stable, was sent to the intensive care unit, and then 2 days later, there was a sudden deterioration, the loss of consciousness. And as you see, we have a preserved flow from the right side, but enormous clot formation behind the flow diverter, obliterating all the pontine perforators. And on top of that, we had a significant stroke in the thalamic area, both occipital artery, and after a very long course in the ICU, the patient ultimately died. So our initially thought of using flow diverters for this kind of aneurysm was shaken. So we started thinking about that carefully. Another basilar aneurysm significantly challenged for the surgeons. These aneurysms generally don't have posterior communicating artery. So in the early days, I remember we used to close the vertebral artery, then wait until the collateral are reconstituted, and then close the other vertebral artery to reduce the size of the aneurysm and the growth over the aneurysm. But frequently, these aneurysms don't present with posterior communicating artery. This is another person, 66-year-old male, with this baggy-looking, large, partly clotted aneurysm, reconstructing with multiple aneurysms. The procedure went very well. We brought the patient back. We do very short follow-ups to assess the situation of the flow diverter and the perforators, and we got very nice result. There's still some filling of the distal part of the aneurysm, some filling proximally, and the perforators, as you may say, as well as the large branches like the ICA or pica, were preserved. This is the construct showing on a vaso-CT here, nice apposition of the device, telescoping placement of the device, and the patient did very well. However, few weeks later, the patient presents with hydrocephalus. We place an EVD. We had to stop the dual antiplatelet therapy for placement of the EVD. And we are working now on minimal invasive solutions for placement of the EVD. This shows you once more before and after shunting. And this is the partially thrombosed aneurysm with some filling distal area. And he did very well, except few DWI hits in the occipital lobe. The patient lived for a year and then expired due to pneumonia. Another patient, 74-year-old male, who has been presenting to us with a history of aortic aneurysm. And it's interesting. Some of these patients with these large atherosclerotic aneurysm of the basilar trunk have frequently aneurysms of the aortic iliac system. And we have to reconsider that these aneurysms may be a disease expression of the entire system. As you see, patient has been following up. Nobody wanted to operate on him in this area in 9, and then 2 years later, brainstem compression with all the associated symptoms like gait disturbance and dysarthria and infrequent double vision. So we placed here again, very straightforward, the technology placement of a thin film flow diverter, fine mesh flow diverter, crossing the right PCA, coming from the left all the way to the left vertebral artery. Here, 6 months follow-up, some filling of the aneurysm partially here. The patient again survived for a year and died of pulmonary complication after a year. So when we summarized this phase 2 of our study, we saw that there was a high occlusion rates of the VB junction. Here, out of 7 patients showed a complete obliteration. And in the basilar trunk, 4 out of 6 aneurysms showed a complete obliteration. And some of the aneurysms still were filling even after a year. We became more and more aggressive. Here, a young man who were flown to us for progressive stroke of the posterior circulation despite anticoagulation and antiplatelet therapy. As you may see here, dissection of the mid-distal basilar trunk, placement of a flow diverter. Technically, these things are not very complicated. And this is a repair 6 months later, a follow-up showing you entire repair with the perforators open and a nice reconstitution of the aneurysm. And here a follow-up on the CTA, mass reduction over time. And this young man is today over 20 and he's doing computer sciences. So very, very encouraging results in some of the patients and bad results in the other. So we summarized our data then and published them recently in 2017. And the paper shows that, and I will show you some cases and summarize our data. Another patient of mid-basilar distal, most likely dissecting aneurysm here combined with coils and flow diverter, nice follow-up. Another young patient with a VB junction, most likely dissecting aneurysm with mass effect of the brainstem, headaches in the past 3 months. We closed the left vertebral artery, placed coils, and bridged the entire area with a flow diverter. And the patient was put on dual antiplatelet therapy. 24 hours later, the patient presented with medullary syndrome. As you see, the whole aneurysm is completely obliterated. The perforators look open. However, when you look closer on the MRI, there is a damage to anterior medullary. And the patient did not recover from that. And that showed us that there is more understanding of this area needed as we advanced. And the data showed also very interesting finding. And the interesting finding were that in our posterior circulation patient, unlike in the anterior circulation, the morbidity and mortality rate was very high with 44% if the patient were symptomatic to begin with. If the patient were asymptomatic in our series, nobody died and the morbidity was 5%. And I will walk you through this in a side. So what about clinical outcomes? You see patient that has symptoms at discharge. There was a significant number of patients that died here, 9. And in the baseline, all these patients that died were presenting with modified ranking scale from 3 or higher. What about angiographic outcome? At follow-up of medium of 11 months angiography, we had a significant occlusion rates, especially in patients that were treated in combined with coils. This was the overall MRS shift in these 51 patients. So once again, the shift shows you an interesting finding. The higher the modified ring scale as baseline, the worse the outcome of the treatment was. That was one of the observations. So the all cause of mortality was about 17.3% and 13.5% directly related to the procedure. And the morbidity was about 14%. When we further dissected, the vertebral artery aneurysms only were 19 patients, and here we lost 1 patient. So again, these patients presented at the baseline with modified ranking scale and had a better outcome. The moment the patient started having symptoms, the outcomes go worse. And that's what the next slide shows. In the basilar artery and VB junction, we had in the series 26 patients. And again, once the patient presented with modified ranking scale 2 or higher in the MRS3 category. We had 5 patients who died and 1 patient who stayed with modified ranking 3. And when the patients were already wheelchair bound or crippled, the outcome was bad. What were the reason for bad outcome in that category? The reason were, like I mentioned, medullary infarction, ischemia 2 hours after placement of the flow diverter, most likely to the perforator density and perforator stroke. Then we had patients that survived it later. They had pulmonary complications due to the mass effect from the still growing aneurysm, while angiographically the aneurysm were closed. And then there were some unknown complications like a brain tumor that led to death in one of the patients. So in the multivariate and univariate model analysis, what we found out that high morbidity and mortality was associated with symptomatic VB junction and basilar trunk aneurysms. So the earlier we treated the patients, the better the outcomes were. It was safer to offer these patients early treatment before a significant brain stem compression or perforator occlusion were present. We learned also that single implant were better than telescoping multiple devices, and that long-term dual antiplatelet therapy was needed. With that said, the last 3 years after the paper, we changed our strategy. And I want to show you some of our cases that we have treated now. And that's what I have been teaching now here in the United States with my colleagues and with my fellows and patients that need our attention. And we have seen now, based on the other data, that this significant neurological complication in the posterior circulation with basilar arteries is mostly related to posterior infarcts, and that leads to high morbidity and mortality. So what have we changed? We are now keeping the patients longer in the intensive care unit. So for several days under very tight blood pressure management. So we prefer keeping the blood pressure just under 160 millimeters systolic, and that seems to be very critical to keep the perforators of the mid and upper brain patent. We heparinize the patients for several days with the PT-PTT 2 to 3 times the baseline. And before the patients go home, we add to the dual anti-treatment, Xarelto or rivaroxaban for anticoagulation. Again, very critical for perforators. So we keep the patients at least for 6 months on dual antiplatelet combined with anticoagulation and do very tight follow-up studies. And I want to share with you 6 patients of different category of the basilar trunk aneurysms where we have successfully done that. And all these patients have been alive now for over 3 years. This is a patient illustrating again why we believe that catching up the disease early in the stage is critical. This is a Fiesta sequence in this patient who presented with progressive imbalance and speech problems. You see a dolichoectasia of the basilar trunk. Here in 2009, the flare sequence, the patient was not admitted for treatment due to the high risk. 2010, 2012, aneurysm is starting growing. And then suddenly there's a massive growth in 18. And that's when we see the patient. And this is how it looks. Partially thrombosed aneurysm, some filling of the aneurysm within the clot. So these aneurysms have their own biological life due to probably upregulation of vascular growth factors, as some of the research have shown, a placement of a single device, and then obliteration of the contralateral vertebral artery. This is a 20 months follow-up showing a nice reconstruction of the artery, no filling of the aneurysm. But when you look at the MRI, the aneurysm is still there. So those aneurysms don't go away. And some of my surgical colleagues then remove the aneurysms like a tumor to decompress the brainstem. I think that's a good idea. In surgical excellent hands, that can be done. Another patient where we are now moving to less and less metal. This is a patient, young lady, 50, completely different disease. This fusiform aneurysm, placement of a single device just to cover the bag of the aneurysm, and then pinning of the different distal part of the basilar trunk with a stent. So we have less metal distally where we receive higher perforator density. And this is a 10 months follow-up with reduction, with some filling of the aneurysm distally for significantly reduction and preservation of the branches. The patient is totally asymptomatic. Another patient with a ruptured aneurysm, we are getting more aggressive now, also in treating ruptured aneurysms. Here, a dissecting aneurysm in a young lady with a bleed. Here, placement of the device, and this is a 2-week follow-up from both vertebral artery, showing you the patency of mid-pontine perforators. Another view laterally showing again filling of the basilar system nicely without. These aneurysms are completely different challenge. They look saccular, but they're associated with atherosclerotic disease. And this patient was earlier detected because of the stenosis and had ischemic events from the stenosis. So we treated the patients early in the stage, and that's very critical. And the patient has been now alive for almost 3 years, and he's doing very well. And on follow-up, the aneurysm is gradually shrinking. We have kept him still on anticoagulation. On top of he has an AFib. Another patient with a ruptured perforator aneurysm of the basilar trunk. If you look closer, you may recognize the perforator aneurysm coming off the basilar trunk. Young lady in her 60s, placement of a single device. Like I said, we want to have shorter devices, single devices. We bring the patient back at 6 days on heparin, still filling of the aneurysm. At 13 days, reduction of the size of the aneurysm. And you may see now at 3 months, complete obliteration of the aneurysm, preservation of the anterior spinal artery that has been covered with a single device. This is the last patient where we are now focusing on how can we overcome the larger distal terminal part of this dolichoectatic basilar artery in this patient who is in his 60s with a third nerve palsy and rhetosis combined. So we place a shorter device, single device, and then to achieve a supranominal diameter distally, we place 2 what we call kissing or double barrel stents here to expand further the flow diverter, to oppose it nicely to arteries that are over 7 millimeter in diameter. And proximally, we have now stents. So less is better, less metal coverage, and we focus our flow diverter again on the back of the aneurysm. And the patient so far has been doing very well. He's near complete recovered from third nerve palsy. And as you might see on the 3 months follow-up, there's this significant remodeling and reduction in size of the aneurysm with less brainstem compression. So we will keep an eye on the patient. He will stay on anticoagulation as well as on dual antiplatelet. I think it is important when we talk to our patients about the basilar trunk aneurysm to tell them the number of morbidity and mortality when we do endovascular approach. And it's very clear for me, from my experience over the last several decades, that basilar trunk aneurysms are not basilar trunk. It's not one entity. First of all, you saw there is a group of patients that are younger female or younger male, and that's a completely different group from generally older male in our population with this atherosclerotic changes that are associated with aortic aneurysm, iliac aortic aneurysms, as well as aneurysms of other parts of the body and the basilar trunk. Completely different entity, predominantly elderly male. Then we are dealing with dolichoectatic aneurysms. We are dealing with dissecting aneurysms that are much easier treated by endovascular means. And then there's a very small group of mycotic or fungal aneurysms. And then, of course, like you saw from Professor Haneshima before, aneurysms of the fenestrated basilar artery that can be nicely treated without flow diverter, generally with stent and coils. Having said that, so what is our recommendation currently based on our experience over the past several decades? I think fusiform aneurysms of the basilar remain a challenge for conventional endovascular treatment. We have to teach our community, our neurologists, that early treatment should be considered before a patient becomes symptomatic and presents with perforator occlusion or brainstem compression. We have to classify these cases very carefully to cite the right morbidity and mortality for endovascular treatment. The flow diverter have changed the management of basilar trunk and VB junction, definitely. But again, we have to pay respect to high perforator density of basilar trunk. Smallest perforator occlusion can be a devastating episode for a patient. Less is better. Do not try to place multiple devices. If you place one device, it's not a perfect result. It's better to bring the patient back and do an elective second placement later on in life. Blood pressure management and anticoagulation management has changed the outcome, especially adding anticoagulation to a dual antiplatelet regimen that can be for several years is helpful to look carefully at remodeling of the entire system, careful remodeling. And infrequently we see a role of corticosteroids and anti-inflammatory drugs, but we are not completely understanding the role. And I think there will be other adjunct medication that will be needed to stop the growth of these aneurysms. With that said, I would like to thank you for your attention.
Thank you, Dr. AJ, for the wonderful and amazing lectures and a lot of case that you show us. So before I will move on to our next lecture guest. So Dr. Bennett have some things to say.
Yes, thank you, Warlick. Thank you, AJ. Let me just show you, AJ, we have, let me get the screen. I got to get on the screen here. So let me screen. I'm going to knock you off and I'm going to put my screen. Okay. Bin Zhu is translating this and it's live now in China. So you are reaching a lot of people, approximately 10,000 Chinese neurosurgeons. So, and we do appreciate Yuha for setting this up and also for Bin Zhu for translating. Ben, are you there? Oh, possibly he can't speak. Oh, he can't speak possibly. But okay, Louis, do you want to hold on to the questions to the end or do them now, or what do you want to do?
I think, good morning.
Good morning.
I think it's better in the final.
Okay.
I have many discussion and many time to discuss. I think it's better.
Okay.
Okay, I have a presentation. Yeah. I can share now.
Oh, okay, I think Louis wants. Louis, should you go first? Do you want to go now, Louis? Or
yes, I think it's better. I because it's the continuous discussion of the presentation of a high WAC loop. Okay.
Okay, is that okay, Ben? Is that okay, Ben?
Yeah. It's okay.
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 Okay, Warlick, can you introduce Louis, please?
Okay, so next speaker is Dr. Louis Igbor. He is our beloved course director of the 5th IMC, NeuroIMC sessions today. He is a really experienced neurointerventionist from Spain. He worked at the Clinical San Carlos, Spain. So today he will give a talk about his experience in vertebral basilar aneurysms complex. Please, Dr. Louis.
Okay. Thank you very much, Dr. Warlu, Waralu, and thank you, Professor Heneniemi and Professor Waklu and Professor Bean to participate and discuss so for this particular type of aneurysm. I like to present some concepts. I think the high Waklu I present some key point, and my key point is different. The invertebral basilar aneurysm is different etiology of the origin of the basilar. For example, in the middle, in the proprius basilar artery, no vertebral, only basilar, the dissecting aneurysm is not frequent, but when you are this, the most important is to treat it with the best endovascular device. The the risk occluded of the perforated branch is high. This is the reason when I don't use the flow diverter in middle path of basilar. This is one example of the, in 2004, with this aneurysm is treated
Dr.
by, yes?
I'm afraid that you did not do a screen share.
Don't you are on the image, the screen.
Oh, don't see any presentations yet, sir.
Any presentation. Okay, just a minute. Okay,
Alright.
okay.
I'm sorry, Wallace, I didn't even pick that up.
Yes. Yes.
Yeah. I'm listening.
Seamless production.
It's okay?
Yes, perfect.
Okay.
Yeah, perfect.
Okay. Don't worry, the first two slides don't have a problem. In the middle part of basilar trunk, I use every time the standard technique. This is treated in 2004, is Jailin and stent, no flow diverter, open cell stent. Why? Because this is the reason you don't have the thrombus of the perforant vessel. This is the control, and this is 1 year control. You are total occluded endothelization of the neck with the neuroform or atlas stent. At this period is neuroform. But sometime in the dissecting aneurysms on this region, this is an example. The initial part of the dissection is here, and this is the aneurysm. This is the angio. This is the dissecting image. I decide to treat with atlas stent and coil, but the radial force, this is after the treatment with coiling, but 6 months later, they regrowth the aneurysm. Why? Because the stent grows to the wall of the part of the dissection. This is the 6 months later, recanalization, and look, this is the stenosis of dissection. And in this point, I decide to treat it with the cardiac stent, Pharos stent, balloon expandable stent, because have more stability in the evolution. You see in lateral view, the balloon expandable stent, and this is the old stent. This is the reconstruction angio. Axial view. It is a control with Pharos. This is previous angio, this is final control. The second point I'd like to present is the dissecting aneurysm in vertebrovascular junction with rupture. This is a typical case with dissecting aneurysm have a lateral bulbar ischemia with the dissection. This is AP view, lateral view in the right vertebral. This is the left vertebral. It's possible to treat it with occluded this vertebral in this part with coil, sacrifice this part. But the problem is the spinal anterior artery is born just at the same level. This is the reason I decided to treat it with coil, stent coil. This is the stent, stenting and coil. This is the stent, Leo stent. Some reconstruction. Another example is dissecting aneurysm with subarachnoidal hemorrhagia in pica. No, sorry, in vertebral. And this, I decided to treat it with sacrifice of this portion of the dissection. This is the pica. This is the spinal. It's possible to occlude this artery in this segment and occlude the aneurysm. It's best solution. Another with a stent and coils. And other group is the pica dissecting aneurysm. Pica, no in basilar, in pica. This is one case I treated with the stent and assisted balloon to liberation of the stent. This is a CT scanner in angio. The aneurysm is dissecting, is in this part, AP view. It's not only this aneurysm. The original and dissecting aneurysm is in this part. Look in the reconstruction. The origin, this is dissect, and this is a blister. Lateral reconstruction. I decide to treat it with cover with a balloon expandable stent, but to protect the moment of liberation, I place one balloon here. In working projection, you are the stent, you are the distal guide wire. When I remove the guide wire, you are many possibility to remove also the stent. This is the reason I open slowly this stent, and when the placement is perfect, I inflate the balloon, and this is the control with the before after. This is after. But before after. In another situation, it's most easy testing. It's possible to occlude the vessel because many times you have the collateral circulation. This is the reason when in this patient I treated by occlusion the aneurysm and the parent vessel pica without symptom. And finally, I like to present some special case which I treated with or vertebral artery occlusion or and basilar artery occlusion. sacrifice of the basilar artery in some special giant basilar aneurysm. This is the first case. It's treated by myself and Dr. Vargas in 98. Bigger middle part dissecting aneurysm. I treated at the beginning with coiling, but many more than 3 times is regrowth the aneurysm. When the aneurysm regrowth in the basilar artery, the problem is the mass effect, not only the rupture, is the mass effect. I decide to treat it 1 year later with occlusion of the basilar artery. Occlusion of the aneurysm, also the basilar artery. This is the control. The patient lives today more than 30 years later. This is the control. Second case, also treated in 89. Is the middle, is a young patient with a middle basilar aneurysm. Probably is the pathology of the wall of the artery. Is a young patient. To start, I sacrifice 1 vertebral artery, and this is the MR control. You have some reduction in the flow. Few years later, the patient don't have the posterior communicant artery and don't have open functional anastomosis of the vertebra. But I decide to treat it with occlusion of the second vertebral and finally the artery. When you have the progressive occlusion of the vessel, the thrombus of the wall not decrease, but the flow change. And I don't know why, still to open the natural anastomosis of the occipital to the vessel. And you have the possibility to have the collateral circulation. At the beginning, you don't have the collateral circulation, but finally, the patient opened the collateral circulation. This is, I close the basilar artery. And this is the control thrombus of the aneurysm and the basilar without symptom. This is another patient, but this is in distal part. I don't present because it's. And finally, this another patient is treated 40 years before with a neurosurgeon in Sevilla, Spain, a giant cavernous aneurysm by clip and ligature, surgical ligature of the carotid. This is the anterior communicant artery. But the patient have 20 years later developed an aneurysm. This is the old aneurysm treated by surgery. I decided to treat it by balloon, bilateral balloon, and I treat it here to produce the high flow in the posterior communicant artery. This is the basilar aneurysm. This is the carotid aneurysm close. This is the basilar aneurysm in this patient. This is the carotid close. This is a posterior communicant artery. This is the AP view. I decided to treat it. Occlusion of the basilar artery. Progressive decrease, the mass effect of the aneurysm. This is the control MR 15 years later. You see the thrombosis of the left carotid aneurysm, the basilar artery, and the patient is total asymptomatic. And the final case is another dissecting aneurysm on the distal part of the basilar trunk, 30-year-old. I decided to treat it with total occlusion of the aneurysm and the basilar artery with the collateral circulation. Okay, thank you. I present this particular case to open the discussion of this complex type of aneurysm. Thank you.
Thank you, Dr. Luis, for as always, like amazing presentations. So let's move on to our next speakers, and then we're gonna accept all the questions from the floor then. Okay, our next speaker is Dr. Bin Su, who is a famous neurosurgeon, and he have experienced a lot of microsurgeries and bypasses surgeries. He's our work in the Fudan universities in China. So please, Dr. Bin Su.
Okay, can you hear me?
Yes, yes.
Okay.
You need to enlarge. There you go. There you go. Perfect.
Okay. Okay. So today I will talk about the treatment of posterior circulation aneurysms from our Huashan Hospital. So in our hospital, most of the posterior circulation aneurysms were interventionally treated, just like Professor Waklu presented. And the only distal ruptured PECA or ECA aneurysms were clipped. So this is unruptured, some illustrated cases, like this is case 1, ruptured vertebral dissecting aneurysm. We can see the dissection, the double lumen sign on the left side, we can see. And so we treated with a stent plus coils, and it can be treated perfectly. So this is a basilar tip aneurysm. Also can use stent assisted coiling and that gets a perfect result. Another case like this is a basilar tip, and actually it's on the PCA P1 segment aneurysm. Also use it's a ruptured. You can see the daughter sac on the dome of the aneurysm, and we use stent assist coiling to achieve the perfect result. And this is a P1 to P2 aneurysm, and still use stent plus coils. And this is another vertebral dissecting aneurysm. We can see the double lumen sign on the 3-dimension DSA. So this is a double layered stenting. And the long-term follow-up is very good. So this is another ruptured thin and flat ruptured vertebral artery aneurysm. We can see the dome was very flat, but it's ruptured. So it's also a dissecting aneurysm. So we use a stent plus coils and achieved the very good result. So only some distal PECA aneurysm is not fit for the interventional treatment. We will perform the clippment. Like this case, a female patient, left vertebral distal PECA aneurysm. So different projection, and we can see the aneurysm was have two domes. So we use this is a incision of the dural, and you can see it's a ruptured one. The exact dome of the aneurysm was larger than the in the DSA because there's some, it's partial thrombosed. Dissecting the two domes of the aneurysm. You can see some nerve fiber attached to the dome of the aneurysm. So temporal clips, proximal part of the PECA, then separated the dome, attached to the cerebellum very tightly. Because there's two domes, so it should be clipped separately. It points to the different direction. Because there's some dog ear. So I change the position of the clip to clip the aneurysm. So this is a Doppler. Show the proximal part and the distal part of the PECA was all patent. So after 1 week, we follow up the ESA. You can see the result is quite good. Okay, thank you. That's all.
Okay, Warlocks? Are you there, Warlocks? Okay.
Thank you.
Taking a nap. We caught you.
Okay, thank you. But I'm listening now. Okay,
Okay.
so it's a question from the floor now.
No question. It's complex.
No, there are. They'll come. They'll come. Okay, questions or comments? Go ahead, Juha.
To treat these complex aneurysms of vertebrovascular system, it's hard contact sport. So whatever you are doing, so you are not sleeping your nights well. This is my experience. You will have surprising complications and initially good results, but then suddenly big despair and poor outcome.
In my experience, when I treated with a sacrifice of the basilar, never have a later complication. But when you treated the patient with flow diverter, you are many times follow-up complication.
My thinking is also that the proximal occlusion in this case is the best treatment. So it is what is coming from the young Richai Behnam Yahromi's PhD in the 519 atherosclerotic monstrous vertebrovascular aneurysms is the conclusion that the proximal occlusion, slow proximal occlusion, is the best treatment. So at least this atherosclerotic aneurysm should not be treated by many stents endovascular because you have the poor outcome with that. Also with bypasses, you will have poor outcome. So I think the best treatment will be the slow closing clip with development of the collaterals and preserving the perforators. So these are different ways for different type of this aneurysm. So it is a general disease, atherosclerotic disease, of course, but also very, very, the patients are extremely sick, and so you have to be careful in treatment of them. So I think it is easy to push a lot of stents inside, but you will be disappointed.
What do you think, Ahai?
So I think for the basilar trunk, we have to be very careful, like all the panelists are saying, to differentiate what kind of an underlying disease are we dealing. You saw from our cases, and I see that when I proctor here or I help colleagues who deal with that, is that there is a group of patients that are atherosclerotic diseased vessels. And on top of that, they develop this monstrous aneurysm. That's biologically a completely different disease. So what we see with these patients is they have a large clot burden in the aneurysm, and it creates an interesting substrate for vasa vasorum. And you saw from Professor Herneshim, I'm sorry that I don't pronounce your name properly. So
it's okay. It's okay. Better than you have all around the world.
Okay. So Finnish is a very difficult language. We know that. So what we have found out, and where we would need a help from surgeons, is the technicality of endovascular treatment is not the problem. You get the aneurysm closed. It looks angiographically beautiful after a year or two, and still the aneurysm is growing. It keeps growing and creates a mass effect. And there are very few surgeons who are willing then to shave off the occluded thrombosed part of the aneurysm like a tumor. You can do it. There is a colleague in the Netherlands, in Amsterdam, who does it. There are some colleagues here in Boston who do it with the same approach that Professor Herneshim was showing us, through a pre-sigmoid approach, to decompress the brainstem. And that's where I think the value would be in combined approach. Again, flow diverter for those aneurysms, very minimal approach, less metal, keep them on dual antiplatelet anticoagulation for a year or so. But somebody has to then remove it like a tumor, because what you said very rightly, Luis, there are these little collaterals, we don't see that even angiographically, that maintain the biological growth of the aneurysm itself. And that's our challenge. The other aneurysms, like we saw, saccular, fusiform aneurysms in a younger population, they are easy treated by endovascular. Again, important thing is we keep the patient on anticoagulation, tight regimen, frequent control, whether it's MRI or CTA. But that's a different disease. They are younger people, sometimes female, ratio is, but the older people with this aortic-like disease is completely different. And there, we are very reluctant. If a surgeon doesn't come to me and says, I will help you later, I wouldn't treat those.
I agree. But for example, one example, patient with 80-year-old arteriosclerotic aneurysm, the picture of angiogram is very favorable to flow diverter, but the clinical symptom is not important. I think it's better to survey this aneurysm and not treat it, because sometimes the flow or wherever you want device is possible to change the flow in the basilar region and the aneurysm growth. I think it's important the clinical symptom of the patient, and the side way is probably the best treatment is not treating the patient in some of the case, because I don't have at the moment the technical. I think the clip, Hernes-Niemi clip, is a very improved method, because I remember of the garrote of Drake technique, of the Charles Drake technique with the basilar artery close, progressive close. I think it's important to wait to the new device to treat this particular type of aneurysm.
I totally agree that there are different types of perturbational aneurysms. So the atherosclerotic aneurysms are a totally different group, like Professor Vaklu said. This is a totally different group. This is a general atherosclerotic disease, and you have to be very careful in treating that. And I think the message should be that you should not push coils or stents inside these aneurysms. This should be the message, because you will not have good results with this treatment. And it is like Luis said, if an 80-year-old patient has that kind of disease, it is better not to treat in any way. This case, just congratulate, you had a long, good life, and then we continue with this disease forward, but no attack on the aneurysm, because you might have extremely bad outcome and death as a result.
And one question to Professor Ahai, also being sure, what do you think when you have a patient, young patient with a blister, like aneurysm basilar, vertebral basilar region? What is the best, because the problem to the stent is the antiplatelet therapy. What is your management? Ahai.
I'm not sure about the diagnosis of the Bristol-like, because the posterior circulation, how can you tell this is a Bristol-like aneurysm? Mostly it's a dissecting aneurysm, and we treat it like, I prefer to use like the Elvis stent. The metal cover rate is around 20%, So combined with the coils, it can achieve the good result, but not so high density to cover the perforators.
You are experience of spontaneous resolution of this type of aneurysm?
Mm-hmm.
Spontaneous evolution and disappear the aneurysm. You don't have a case? You know? This possibility is sometimes it's possible this. See the patient survive,
Yes.
it's possible. And what do you think about Professor Waterloo?
So what we have done is we have blister by definition are aneurysms that are ruptured. So like you said, Luis, the problem is the antiplatelet therapy. So we have translated our experience from the anterior circulation where we use single or two overlapping stents, like Professor Bin Shu is saying, and we have achieved good results. The problem is that the aneurysm angiographically disappears, but few days later, patient may re-rupture and they generally don't survive. Its low rate of re-rupture is probably around 10%. The experience is very limited, as you know, from the literature. My own experience has been in the basilar also. I showed you a perforator aneurysm. We have some blister aneurysms. I try to stay more conservative. I try to bridge the first few days if we can do, and don't do any treatment, because the thromboembolic complications in the early stage of ruptured aneurysm is very high because the body adjusts with a hyper response in the clotting. And that's something we need to consider. So if you can get the patient the first few days out of the worst situation, and then come back and do the placement of a flow diverter or a stent, it's better. It's better, it's safer. Now, if you can do surgical wrapping, which is very difficult, I'm sure, in the mid-basilar or distal basilar. So we talk to our colleagues and we, like I said, we wait 3-4 days and then place a flow diverter. Again, single device, small device, short device. And then it's safer to put the patient on dual antiplatelet. That's how we do it. But the risk is high of rebleeding, of course. It's not insignificant.
Professor NeuroIMC, where is the difficult to treat it? The aneurysm is localized in the ICA superior cerebral artery amplification. Is difficult? Surgery technique?
Yeah, what kind of aneurysm? Saccular? Saccular.
Yes.
Saccular you can manage well. Saccular aneurysm you can manage well. I have not seen basilar dissecting aneurysm. These are not in our experience.
Saccular.
Yeah. But I was just saying that I didn't see any basilar trunk dissecting aneurysm. The dissecting aneurysm were in the pica, in the vertebra, pica proximal or distal in the pica. These were dissecting aneurysms, but I have not experienced any basilar trunk dissecting aneurysms. So the saccular can be treated very well by clipping. Whatever, at a mid-basilar trunk, pre-sigmoid approach, or some people are doing Kawase approach to these aneurysms, but you can clip them well if they are saccular.
Okay, I believe Danu, welcome from Indonesia. I believe he has a question for you, huh? Danu, can you,
Yes.
Go ahead, Danu, welcome.
Thank you very much, John. It's been a pleasure and an honor to be here. I'm Danu from Indonesia. I have one question for Professor Juha. Considering your enormous and many experience year after years, I was wondering how was the aneurysm clipping surgery by the earlier time when CT angiography was not always available. Is it possible to do it? Considering we don't have the luxury of CT angiography in every hospital in our country. So by looking at for example, we have SAH and we can see the pattern of the SAH and the ICH, intracerebral hemorrhage by the rupture of aneurysm. Can we guess the aneurysm, and we can do the surgery.
I clipped my first aneurysm 1976. So that time it was angiography until 2000. Then we began to use CT angio because we had excellent pictures with CT angio. We didn't have any more DSA in Helsinki for direct surgery. So I don't, you have certainly DSA, angiography.
DSA angiography, not in my hospital, we don't have it yet. We only have the
angiography. But then you should, when you have CT, then you can easily achieve CT angio to this machine. So it should not be so difficult. You can have that kind of computer system. So it should start technicians. So it should not be difficult to do it. It's not expensive, and you can add CT angio to the regular CT, but with regular CT you cannot operate aneurysm. I have done with hematomas, but you should not do microsurgery without precise goal where the aneurysm is. If you have even bad pictures, if you know that there's MC aneurysm or ACAM aneurysm or carotid PCAM aneurysm, then you can do surgery, but you should have CT angio. Or if you don't have DSA, then it is very difficult to do microsurgery. This is like to go back to 1930s when Dandy began his aneurysm. So without angiography, it with oculomotor paralysis you can do. Then it is become aneurysm, but this is seldom that you can find the aneurysm. Or try to achieve CT angio. It is not so expensive to have this extra in your CT machine.
Yes.
Which city you are? Which city you are?
In Jakarta.
Jakarta.
You went to Jakarta when I was resident in University of Indonesia, Jakarta. I saw you work on
Jakarta. You have high-level neurosurgical institutes.
Yes, but I work in other hospital, and the principal of the hospital asked me to develop the neurosurgery facility in my hospital where I work now.
Okay, then achieve good angiography. CT angiography is not very expensive as added to the CT machine.
Yes. Thank you, Professor.
Professor Waklo, so according to your experience, how often is dissecting aneurysm posterior circulation? Because in our hospital it's quite normal, especially in the 3-dimension aneurysm reconstruction. We can find the typical double lumen sign, so we can say this is a dissecting aneurysm. But Professor Juha said he didn't see any dissecting aneurysm of basilar trunk. Yeah.
May I comment? Yeah. Because I think in China you have huge number of atherosclerosis. So this is coming from the male smoking and both genders fatty food. So you have huge number of atherosclerosis. So then you might have dissecting aneurysm also in the basilar trunk. But in Finland I have never seen.
Okay.
So Professor Binchu, sorry. Go ahead. So, Professor Binchu, I think that you make a very good point, and so does Professor Haneshim. The thing is that I think the dissecting aneurysms are focal, that certain regions in the world see more, like in Asia. But I have seen a lot of dissecting aneurysms in our practice here. Generally, dissection of pica, dissection of the junction between the origin of the pica and the VB junction. And frequently these patients present with subarachnoid hemorrhage, and it may be not evident immediately on the angiogram. But like you said, if you do vessel wall imaging with short TE times and contrast, and you do fat suppression, you will see the point of dissection in the wall very nicely. So most common, like we were discussing, most common locations is the pica, VB junction, and basilar trunk. We have also a whole group of patients that have dissections from distal basilar into the PCA, P2 segment, P3 segment dissecting aneurysms. And our policy has been in the past to take down the artery when we can. So the best thing is either endovascular surgical takedown of the segment that has ruptured. If we cannot do that, like Louis showed a case where you have the anterior spinal artery coming, or whether the anterior medullary segment is involved, then it's safer probably to use coil whenever you can, or use a stent or a flow diverter to overcome the dissection. But we see a lot of dissection that remain also asymptomatic, except that the patients had headaches. So basically contained dissection with narrowing of the artery or fusiform dilatation. But some of the patients present with a three-layer dissection with a subarachnoid hemorrhage. But I think dissection is more common than we believe. And you are absolutely right. Maybe more in Asia.
Yeah. So how about the indications? Because if you found some patient with only headache and with dissecting, would you treat it?
We follow them up. So if there's no subarachnoid hemorrhage, we put the patient on antiplatelet treatment and then follow them very tightly with imaging.
Mm-hmm. Okay.
You're on mute, Luis.
Okay. Some patients in my experience come from player golf.
Yes.
Be careful. Player golf is the origin of this dissection. I have some patients with bilateral dissection, and the key point is discussed is some patients don't come to hospital in acute phase, going to the rehabilitation or traumatologist. And some patients, when you check with CT scanner, don't see the bleed. Also, it's possible the neuroradiologist don't study well the basilar, vertebro-basilar junction on a CT scanner or angio. And finally, sometimes it's very small, and the only right possibility to the diagnosis is the 3D angio, conventional 3D angio, because it's a very, very small lesion of the wall. This is probably the reason with in Europe or USA you are less to China, but the case normally is less to arteriosclerotic, but with the player golf is not. I have a comment. One question for it's important. What I understand your presentation, you have a comment with the steroid. What is the paper of the steroid to treat this type of complex aneurysm?
So Professor Hennesch-Niemi showed some cases of this dolichoectatic and these large aneurysms. And during surgery, when he opened it up, you see there's a lot of atheroma, but a lot of vasa vasorum also. So when we looked at patients that died histologically, what we find out is that there's an enormous, and I think the Finnish group with Niemela and his whole researcher showed it nicely, that these large aneurysms with huge clot burden have a huge activity around neutrophils and PMA cells. So they express a lot of myeloperoxidase, which is a toxin. So this myeloperoxidase upregulation creates an MMP, which is metalloproteinases, and those metalloproteinases destabilize the matrix of the aneurysm wall. So what they see is a lytic effect with breakdown of the vessel wall of this aneurysm. So what we have found out that could be learning from the other areas in the body, that high dose corticosteroids may suppress some of the inflammatory enzymatic activity around the wall. Does it work all the time? No. Then the other thing is what people have been discussing is that there is a perifocal edema after placing flow diverter or coils that's generated by inflammatory response. And we have seen that in anterior circulation with giant MC aneurysms, there's a huge perifocal edema and it keeps on growing. And with high dose corticosteroids, you can control them. It's more, I think these aneurysms are more like a tumor characteristics than really vascular disease per se. But I would love to hear your comments.
No, I agree, because in our practice, the neurologists don't like to use the steroid. I don't know why. The neurologist, the clinical neurologist, but the neurosurgeon I like. Why? Because the mass effect and the mass bum in the wall to the parenchyma is really, because you see in the MR, you image, you are some change around the aneurysm. This is the reason when I think it's important to treat it before and 1 week later in my practice. Just before, and the neurologist I don't like, but I am endovascular neuroradiologist. I think it's the same idea of experience of the neurosurgery. One question for the Professor Bing. What you have in China, the capacity to evaluate the flow, inflow, outflow, or onflow with the image inflow in the aneurysm with the CT scanner or another method? You are the study of the check the flow in flow and in the aneurysm, no, or not only in the basilar region in general.
Yes, we have some NOVA system to measure the blood flow.
You are a comment?
Volume.
You are a comment from this?
No, not commonly used.
No comment.
Because we performed the DSA by ourselves. So normally we can measure the blood flow according to the DSA presentation. So if we need to measure the outcome and the income flow, we will use the NOVA system. It's a MRI sequence.
Yes.
It's designed by Professor Fadi Chaper.
With MR?
Yes, with MI.
And
sometimes we measure the blood flow for the bypass intraoperatively. Yeah.
I think it's interesting to check.
Yeah.
To check you need to sacrifice one vertebral artery. It's possible to check what is the secondary effect.
Yeah.
With MR.
Yes.
I don't know. Normally it's with CT and just CT, but
Normally we will, sometimes we will maybe perform some blue occlusion test before we sacrifice it.
The control, the pressure level is important in the arteriosclerotic basilar aneurysm. You are a special management of the control of the pressure. How is the level to the old man or Chinese man? How level you decrease the pressure blood? How many minutes?
You mean the enhanced balloon occlusion test?
No. In general, in the arteriosclerotic aneurysm, classic aneurysm, a high value present this comment also is important to control the blood pressure. No, where is do you think?
We keep the blood pressure at the baseline. Yeah. If we perform the
sorry. Go ahead.
If we perform the CEA, like today I have a CEA case, we were elevated the blood pressure during the occlusion of the ICA. And sometimes we do some enhanced balloon occlusion test. We will decrease the blood flow, blood pressure around 30% of the baseline. If the patient still can tolerate, you can sacrifice the parent artery directly. Yeah.
How long? Half an hour?
30 minutes, yes.
30 minutes. Okay.
Yeah.
Okay.
AJ, you had something to say?
Yeah, I wanted to comment regarding test balloon occlusion. So we do the same way. We reduce the blood pressure from baseline 2/3 by using nicardipine and control it for about half an hour and do SSPs and evoke potentials if the patient is not awake, otherwise neurological exam. However, I have to caution everybody that a patient can pass the balloon test occlusion, and then you close both vertebral arteries, you achieve a very good result. Patient wakes up fine, goes to the floor, and few hours later, the patient is completely locked in. I have seen that. We have to be very, very cautious. Young people being done other places, both vertebral arteries were closed successfully, very nice posterior communicating arteries filling the artery distally, and suddenly the patient gets locked in, and you do an angiography, and the whole basilar trunk is thrombosed. So we have to be very cautious how to really interpret this balloon occlusion in the posterior circulation. Anterior circulation is a different beast.
In the posterior, in my experience, is the patient is not general anesthesia, is with the local anesthesia.
With conscious sedation, yes.
And test the patient. The potential evocate is not true. And when I finish the occluded, both vertebral or the basilar, I put the patient with a high pressure about 2 points or 3 points, and stay with the radial control, very, very important. And also the patient is by nimodipine, and the nimodipine, the problem is decrease the blood pressure, and this is the management of the intensivist care in my center. It's complex.
Yes, personally, I never sacrificed both vertebral artery.
Yes, I have only 5.
Side, yeah.
No, 5 basilar. Another comment, Juha, what do you think?
For the atherosclerotic aneurysm, I would wait. Dr. Jahromi's PhD. He has a huge material, 519 cases, so we will have new information. So I don't want to speculate anything here. about the pressure. So Dr. Drake used to have an interval between the vertebral artery occlusions. So first one side and then other side, and then the low vertebral artery occlusion, so that the collaterals were there through the. If you occlude the vertebral artery very low at the C1 level, then you have collaterals then through the muscle branches, and they develop, and you might have better outcome if you don't occlude immediately in both vertebrae at the same time, and you should occlude them low, and nowadays you can occlude them endovascularly low, so you don't have to do any surgery, destructive surgery. I think this is the wise approach. Those patients who became locked in, did they smoke?
No, it was a young girl, 14-year-old. Was somewhere else where that was done, but it was a pediatric patient.
Okay, we have seen that also at sudden death. So yeah, this like I said, it is hard contact sport. So it's difficult, and we don't know everything now. So we hope to get more information and to get more wise in treating these cases.
But the sacrifice of the vertebral is you sacrifice one time, and 1 week or 2 weeks later you close the another one. This is important.
Yeah, it is important too.
But I have I remember one case when I work in Paris. I sacrificed a giant aneurysm of vertebrovascular junction, and my professor La Junior sacrificed this. Why you sacrifice the right vertebra and not the left? My question is, why you don't sacrifice, you choose the left or the right vertebra? Talk me with the anatomy, blah, 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 blah. But the patient developed progressive growth, the aneurysm, after sacrifice one vertebra. I don't know why. You change the flow. Be careful. Sometimes it's difficult to know where is the best or point to close or vertebral, because the flow is possible to change to reduce the volume of aneurysm, also to grow the aneurysm. This is difficult to understand. I remember one case is complicated, very, very disaster case.
Okay.
Very good. Any more comments, questions before we close? Okay, I think great session. Thank you very much, and thank you especially to the Chinese neurosurgical community for coming. And Ben, I'd like to thank you for translating. Again, thank you very much.
You're welcome.
And thank you, AJ, for coming early from Boston. And Louis, of course. Louis, do you have the schedule for 2 weeks from now? Do you have an
No. I like to, I think, stop to and restart in January.
Okay, very good.
I have a good for you. I think it's possible you come to Madrid in February.
Oh, I would love that.
Yes,
because I tell you, I want to tell the audience that
I have a special place with a small mafia, NeuroInterventional mafia.
Okay.
And,
good.
No more than 12, only 12.
Okay, 12th of February?
Say, I think February or March. It's not, the date is not important.
Okay, we'll let everybody know. It's a great conference. It's a real Madrid experience.
Yeah, great.
I loved it. I went there a couple of years ago. It was fantastic. And I'd like to thank the audience for coming. And we have a neuroanatomy lecture shortly, and you're welcome to come with Ip Cherian. So Until next time, thank you very much.
Thank you very much. Thank you,
Thank you.
Varalux.
Bye-bye.
Also,
Thanks.
Happy,
Bye-bye.
happy
Bye-bye,
New Year,
everybody.
everybody.
Yeah, happy holidays, everybody.
Bye.